Trauma creates lasting effects on spinal joints and compensation of the intrinsic and extrinsic spinal muscles. Stay tuned because today you will discover how to diagnose the precise biomechanical compromise and new concepts and applications for calibrating spinal stabilizing muscles. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute, and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain based solutions to recover from head and neck injuries and improve neurologic function. I'm honored to welcome our next guest expert. Dr. Russ Hornstein is highly dedicated to the study and accurate assessment of spinal biomechanics and the effects of trauma on joint stability. He has developed a new high velocity, low amplitude method called adjusting to neutral, which is proving to resolve joint dysfunction precisely, quickly, and with greater comfort to patients without in range loading. Today, he'll be sharing with us, is it possible to completely resolve the effects of neck trauma? Dr. Hornstein, thank you so much for joining us today on the Virtual Neurology Summit. Please take it away.
Okay, great. It's great to be here, and thanks for having me. And so I want to talk about how we've been doing things over the last 125 years, and maybe some new concepts of how we could create longer lasting results and be more effective with our treatment. So much of chiropractic has been focused on ranges of motion. So range of motion is a very, very easy thing to test. Because people will come in complaining about their lack of mobility or the lack of function due to this muscle tension. And extrinsic muscle tension is often painful and fatiguing. These extrinsic muscles that limit our motion or limit our range of motion are really designed to be contracting to move us rather than to hold us. So if they're contracting all the time, holding us, that creates changes in metabolism of the muscle, obviously, creates pain and fatigue in those muscles. So it's very clear that that's a source of pain with our patients. So it's something that's a very, very obvious thing to start with. It's also very, very easy to test because, ranges of motion are very people are very aware of their own range of motion. They'll tell you very quickly where it's restricted, and we have lots of tests that are devoted to that as well. And we also know that high velocity, low amplitude end range adjusting can improve our ranges of motion. We can see immediate changes with our patients when we adjust. But we also need to look at joint stability. Now, joint stability is something that's often dealt with after we improve the range of motion. But we want to kind of look into what makes a joint unstable so we can kind of figure out what might be the best way to do things. So joint stability is determined by these deep muscles, we call it the intrinsic muscles. So a decreased tone or a reactivity, and by reactivity, I mean the capability of that muscle to contract. A decreased capacity of a muscle to contract, particularly intrinsic muscles, could come from two main sources. One is a decreased output of the vestibulospinal tract, which is obviously a descending tract from our brain stem, which is reflexive, and that will basically turn on those stabilizing muscles and will respond to vestibular inputs. We'll go into that in more detail. But that's sort of a top-down thing that's going to control the tone of those postural or intrinsic muscles. Another thing that can affect the tone of those muscles is local inhibition at a specific joint. So that's what happens when we have a joint trauma. So if we have a joint trauma and our head gets thrown forward in one direction, it's going to stretch a lot of muscles, and that very high velocity stretch will reset the gain of those muscles and essentially making them less reactive and with less tone. So we're going to dig into that in just a little bit of detail. First, I'm just going to take a quick look and just kind of establish the language here between extrinsic and intrinsic muscles. So extrinsic muscles are the ones that are under our voluntary control. They destabilize in the sense that they're actually taking us away from our stable and neutral position by pulling us to the side. They pull us laterally or they rotate us. But every time that the extrinsic muscles are contracting, they're not really stabilizing us. They're pulling us away from our stable position. They're under specific control because they're under our conscious control. We can switch on or off different muscles quite precisely. And they also have a short-lived reset of gain. So any muscle that gets stretched kind of beyond its capacity to resist that stretch will have a resetting of the gain. So that's a kind of a lengthening again or a decreased reactivity of the muscle. And what's going to happen is with the voluntary muscle that has a very short cycle. So in other words, if you have a whiplash, the next day your extrinsic muscles are going to be tight. But we also know that we're going to have problems with our intrinsic muscles. So let's look at that. So intrinsic muscles are not under your conscious control. We can't consciously turn on multifidus between C5 and C7. It's not possible. They're reflexively controlled, and they're tonically contracting to stabilize. So they're meant to contract tonically, which means to hold the joints over time. So the way that those muscles are contracting isn't necessarily grossly moving the joints, but kind of applying more pressure to one side or another to give it more support. Also, those intrinsic muscles have a very, very profound effect in controlling the biomechanics of the joint. So as your joint is rotating, the muscles on one side will be contracting, the others lengthening to allow that rotation and translation of your joints to take place effectively and accurately. They're also controlled as a group. So the part of the brain that's controlling those intrinsic muscles is controlling many muscles all at the same time. So essentially, if you tilt to one side, your intrinsic muscles are going to be activated on the other side. So we don't have the individuated control. They work as a group. And also they have a very, very long lasting effect. So if we stretch an intrinsic muscle with a high velocity stretch and reset its gain, that lengthening or the decreased reactivity of that muscle is going to last for weeks, months, or even longer. So we're going to look into that in a little bit more detail. So what changes muscle reactivity? Again, high velocity stretch, a force greater than our body's ability to resist. So really we could be talking about trauma, or we could be talking about our chiropractic adjustment, because they're both high velocity stretches. And when we stretch a muscle faster than our body can respond to kind of make it contract to stop that motion, then we're kind of getting into sort of the danger zone of the muscle. So it's kind of beyond the kind of what I call the speed limit of the muscle or the load limit of the muscle. If the body were to continue to contract, it would actually just rip the muscle. So it has to do something else. And that's what we call resetting the gain or decreasing the reactivity of the muscle. So it's less able to contract or less likely to contract. So that can be a good thing. So just in this picture here, you can see that the intrinsic muscles are close to the center and the extrinsic muscles are further away. So if we imagine a scenario, I have another picture here in a second, but if we imagine a scenario where your head gets driven forward and to the left, like left anterior, then the muscles on the right posterior will be stretched. So if we have a whiplash that throws your head forward to the left, the right posterior intrinsics and extrinsics will both have a resetting of the gain to make them decrease in their tone. But what would happen is that, again, like the next day, usually the extrinsic muscles will contract back up again, and then we end up with that stiff neck. But again, the intrinsics have that longer lasting effect to the resetting of the gain. So those intrinsic muscles will stay less reactive and less capable of contracting. And that's where we see those instabilities following a neck trauma, neck or head traumas. So, but another thing is that we need to bear in mind is that when the right posterior intrinsics are inhibited, normally when a muscle is contracting, it can inhibit its antagonist. But if the antagonist to the right posterior is the left anterior, then it's going to be harder for it to resist that. So here I have it drawn out. So imagine that this arrow is throwing the joint left anterior. You can see that the wavy blue lines are showing the right multifidus and the right intertransverse area being stretched by that. And that's going to reset the gain of those muscles. So if those muscles are less capable of contracting, and these are intrinsic muscles, what will end up happening is the opposite intrinsic muscle. So here we're showing the left intertransverse area will get tight. And what it will do is it will because it's uninhibited, it will get tighter and tighter. And as it gets tighter and tighter, it will further inhibit that multifidus. And that's what kind of locks in these subluxations. So very often we see subluxations that are just stuck for ages and ages and ages. We don't seem to have a good mechanism for it. Now, if the body stayed in like this, so here, the effect on the spinal muscles, we just have a few details. It's a left anterior force. It's resetting the gain of the right multifidus. That lowers the reactivity or the tone of that right multifidus. So we know that multifidus is really important for posture and for good spinal stability. So if we've had a trauma such as this, we know we're going to have a compromise of the stability of the spine. And if it can't contract, it can't inhibit its antagonist. So the extrinsic compensation in this picture, you can see on the right side, I'm drawing probably fairly poorly. See the erector spinae which is an extrinsic muscle contracting to try to compensate. So if we have a failure of the intrinsic stabilizers, we have excessive left anterior motion. So every time that person's bending left anterior, they don't have stability to stabilize their spine. So we're going to recruit the right posterior extrinsics. But we also have that left anterior restriction at the same time. So we have intrinsics and extrinsics doing this kind of weird pattern. And I'm actually drawing it very, very simply. It's much more complex than this, but just for the sake of simple understanding, this is kind of the relationship between the intrinsics and the extrinsics. So that restriction of the left anterior, or sorry, the left anterior tension, or here in this example, the left intertransverse area, is going to restrict that joint from coming back to neutral. So we have two issues. One is that the joint can't come back to neutral because of those intrinsics, and the other is that the joint can't go towards the traumatized position because it's being held, it's being prevented from going into the traumatized position by this compensation, which actually you can understand that there's a purpose and a reason for those erector spinae to be tight. So post-trauma, the joint function is going to change. It's going to be unstable in that vector of trauma. You're also going to have extrinsic loading. So in other words, that posterior erector spinae is going to be putting a load on the joint. Remember, it's trying to pull it to the side, but with all these muscles tight, it's just going to load the joint, and that's going to accelerate the wear and tear in the joint. It's also going to alter the axis of rotation because those intrinsic muscles are now less capable of guiding the biomechanics of the joint appropriately. We're going to have less capacity to resist translation, and translation in the lumbar spine is flexion. So the multifidus is going to help to prevent that or try to hold us in flexion. So a weak multifidus is going to equate to a lesser capacity to resist translational forces, particularly with heel strike. And we're going to have, so basically what's going to happen is everything's going to be tight, and we'll have a decreased motion in that joint. If that joint isn't moving as much as it should, we call that deafferentation. So the neurologic consequence of a joint not moving means you don't get that proprioceptive input from the joint. Now, it has one sort of effect in the lumbar spine, but a greater and greater effect as we go up into the neck. So when we have cervical problems where we have deafferentations, or we have several subluxations, I'm sure we've all seen patients with more than one subluxation. You imagine each of those joints as they're moving and creating afferentation. Those are like power stations that are driving our nervous system. So it's literally like shutting down power stations, deafferentation. So subluxations are a huge, huge problem, and we definitely need to resolve that. So there's an altered motion as well. So like I was saying, the biomechanics, and that creates a disafferentation. So that's kind of a neurologic way of saying that if the joint is moving badly, it's not moving the way that our brain is telling it to move. So if our brain says, move, laterally flex to the right here, this joint is going to have a problem with that because it's just not going to move because we have all these other muscles tight. So the feedback is the brain is going to tell the brain that the joint itself, the proprioceptors are going to say, I didn't move that way you told me to move. So that creates what we call errors in the system. So this is how we typically would be addressing it by adjusting and by trying to increase range of motion. So typically what people will do is do end range adjusting on both sides. So I was certainly trained to do that. If someone has a lumbar problem, they're going to have joints that are restricted in both sides. And if we do a really, really good adjustment where we get lots of cavitations, we're going to be moving all of the joints. So we're not really being, we can take contacts on certain joints, but if we're getting lots of cavitations, we're moving lots of things. End range adjusting will very typically take place with some degree of flexion, with an increase of flexion as we thrust. So it's when we bring the knee up and you roll the pelvis, you're going to be getting a little more flexion there. And also we're going to be rotating the spine, and that rotation on the spine is going to be stretching many types of muscles. So any muscles that we're stretching, and when we go to the end range, we're going to be stretching intrinsics and extrinsics. So it's not really discriminate at the end range. You're going to be hitting both. So that may or may not be a good thing. We'll see in a second. So, and again, because we're adjusting several joints at once, we're not really calibrating one joint in relation to another. So our kind of general adjusting, and we can try to be specific, but if we're getting lots and lots of cracks, we're not just adjusting one joint. So if we're adjusting at the end range, like I said, we're affecting both intrinsics and extrinsics. So we're not really being specific to that intrinsic imbalance. So I'm basically working my way around to explaining the approach that I've created to resolve this, which is looking at the spinal stability issues first and those intrinsic muscles. So rather than looking at restrictions of end range, where, yes, it is important to improve the end range. I'm not saying that we don't, absolutely. But what might be important would be to look at the spinal stabilizers first. So here's the idea. We addressed two different issues in the last image and scenario, where the joint can't get back to neutral, but also it's being prevented from going into the traumatized position by the extrinsics. Now, if we do a normal adjustment where we're offloading those extrinsics, we might actually be leaving the joint less capable of compensating an underlying weakness. So we could be leaving the joints less stable. I don't think it's really as bad as that, and it's more of a complicated answer. Probably we're getting enough afferentation that we're activating the vestibulospinal output a little bit, and kind of decreasing that negative effect, if you would. But it's kind of like having your foot on the accelerator and the brake at the same time. So with adjusting to neutral, what we're looking at is trying to reset the gain of that antagonist. So whatever muscle has been traumatized, its antagonist, so here I've drawn the intertransverse area, will be tight. And that tight muscle is going to be inhibiting the originally traumatized muscle, the multifidus. So if we can reset the gain, if we can create a stretch on that intertransverse area, then we're going to reduce the inhibition of that traumatized muscle. That's the idea. So that would create a greater balance of these intrinsic stabilizing muscles, and to further calibrate the joints. Okay, so this isn't really a difficult thing to do. It's a little bit of a difficult thing for us to get our heads around, but it's an adjustment that looks like every other adjustment. People look at it and say, oh, it doesn't look that different. But when you feel it, you're like, wow, that's a completely different thing, because we're not moving the joint to an end range. And the adjustment itself is a translational adjustment, taking the joint from wherever it was stuck in the trauma and just literally driving it back towards a neutral position. So if we can get that joint to be back in the neutral position and stabilize in the neutral position, so that that multifidus that was previously being inhibited is not being inhibited, it can contract now, then we have greater spinal stability. And then guess what? We don't need those compensating muscles to be tight. So all those extrinsic compensators will decrease in their tone, and we see, guess what? Greater range of motion. So this is kind of a different concept, but one where I think we can really make some big strides. And certainly for the practitioners that are using this, we're seeing that. So the one thing we didn't mention here was vestibulospinal output. So obviously that's sort of the top-down function of spinal stabilization. So we can do postural training, which is great because it reduces the stress, and it also builds more function in those compensating muscles. But that alone is insufficient to create a lasting increase, particularly in the vestibulospinal output. But again, because that's not a consciously controlled system, it's a very, very difficult thing to say, okay, we'll just pull your shoulders back and your vestibulospinal output is going to be working. Obviously, that does benefit us. We know that. Again, we're reducing the stress and building function and compensation, but it's not going to be the way to create vestibulospinal output. Now, we can do that, obviously. So I want to look at this for a moment. So one is stimulating the vestibular system, because we know that proprioception is kind of a joined function between the proprioceptors, the vestibulospinal input, and our visual input all come together, and they all integrate in our brainstem. And that sort of summation of understanding of where we are and how we're moving is what is going to direct and control that good output of the vestibulospinal system, and again, give us that spinal stability. So we know that vestibular stimulation, moving around, is going to be good for activating vestibulospinal function. There's lots of rehabilitative things we can do with the vestibular system. And we can also do balance training. That's all very, very good. And gaze stability using our extraocular muscles. Again, that's feeding into that system. And they all have a greater potential to increase vestibulospinal output. And we should absolutely be doing that in our practices. But there's a small issue with that. It's when there's deafferentation or disafferentation. Because again, this is an integrative system. So if we have less stimulation, or easier to understand. If our joints are moving badly and we're trying to move our joints to kind of make the system all understand where we are, it's going to be difficult because the quality of the information that's coming in has been skewed. So that those therapies rely really on sufficient and accurate proprioceptive signals from the joints, especially the spine, the inner ear, and vision. So again, if there's any sort of disagreement or a sort of a lack of precision or kind of I suppose, accuracy of the reality of how we're moving that's coming in from these receptors, then it's going to make it very, very hard for those therapies to function properly. So when we rehab on top of a spinal deafferentation, we're basically saying, imagine that we're not getting enough stimulation from our joints in our spine because they're also stuck. Then what we're going to be doing is upregulating the other senses. We're going to be upregulating our vision. We're going to be upregulating our vestibular system, or you're going to give people tools like sticks to use and things like that that give them a different proprioceptive impact to try to make that system function properly. So deafferentation also cuts the total afferentation to that vestibular nuclei. So the strength of the output of that vestibular system is also going to drop. So really, so again, it kind of goes back to just, if you can get the joints moving, you're going to probably increase the potential output of that vestibulospinal system. But unless we're doing it in a way where we have spinal stability and good joint stability, then it might not last. And so that's why probably our patients are coming back after every few days and we're seeing the same listing showing up again. So when there's a disafferentation from pathomechanical joints, that creates these error signals I was talking about, and it's hard for our brain to tune that out. It's kind of like there's all this noise in the room, and we're trying to figure out what's good information and what's bad information. So anytime we're trying to throw any type of rehabilitation into our proprioceptors that involves proprioception, it's really, really hard to calibrate it. So again, it really comes down to those poor inputs. So if we don't have good quality inputs, then it's going to be very, very difficult for us to create lasting change and positive fast change. So just last few points here. So treating the local intrinsic failure is going to, for one, resolve the inhibition of those intrinsic muscles. Okay, so the ones that were traumatized. We're going to restore the joint stability in that vector of trauma. So again, if we can switch that multifidus back on, then when we move in the vector of trauma, it's going to be there to stabilize us. We've reset the gain to, or we've removed the inhibition and allowed for greater reactivity of that muscle to stabilize. Again, if we have good function between all of the intrinsic muscles, they're going to be able to control the axis of rotation of the joint. They're also going to be better capable of controlling the translational motions. So as we have heel strike, one joint is going to slide over another. So that translational type of function from impacts is also held and stabilized by those intrinsic muscles. So we have a better ability to stabilize ourselves with heel strike. We also have a decreased extrinsic compensatory tension. So that will restore our range of motion because there's nothing there. They can go back to doing what they're supposed to do, which is to move us rather than to hold us. And we'll have improved joint mobility. And when we have more joint mobility, we have greater proprioceptive activation. So again, that's going to be great for that whole afferentation thing, and also, again, boosting not only the vestibulospinal or the vestibular nuclei and our vestibulospinal outputs, but literally everything to the brain. Our brain is being driven by proprioceptors. So this is really going to help so many things. And it's also going to decrease the errors or stop the errors and that disafferentation. So then when our joint, that basically means our joint is moving well. All the muscles that can stabilize us are functioning well. All the muscles that move us are functioning well. And in that scenario, when we have joint stability, we have strength, we have flexibility, because the extrinsics can do they can do their function of strength and flexibility. The intrinsic muscles are giving us postural tone and that endurance to keep ourselves upright. So, sorry to talk so fast, but there was a lot to say there, and that's kind of the general idea of it. So I want to just thank you for watching, and just also explain just in a little bit more detail. Adjustment neutral is a very, very gentle technique. All we do is we set up the joint in that subluxated position or fixated position, however you want to call it. and we feel where there's resistance of the joint coming back to neutral. When we do the setup that I've created here, you can literally thrust on it, create a very, very specific translational thrust, driving the joint back towards a neutral position and resetting the gain of the muscles that are preventing it from coming to neutral. And again, create balance of those intrinsic muscles. And immediately we see not only greater stability of the joint, but an increase in range of motion very, very quickly, because the extrinsics will very, very quickly melt in front of our eyes. So thanks for giving me the time, and I hope that's interesting to you. Obviously, this is a very, very quick overview and quite simplistic explanation, but I think we've gotten some of the main points across, and I look forward to everyone hearing this. And if you have any comments, just feel free to reach out to me.
Wonderful. Dr. Russ, thank you so much. What a wonderful presentation. I took a ton of notes over here. I'm going to do my best to synthesize, and then a couple of questions for you to get started with rehabilitation.
Sure.
So first, you mentioned spinal stability versus range of motion. So why do we focus on range of motion? Because it limits mobility and function. Extrinsic tension is painful and fatiguing. There's a link to pain. It's easy to test. We've all been taught to test it, so it's part of our normal flow. And then high velocity, low amplitude in range adjustments can improve range of motion post-adjustment. So what makes joints unstable? Decreased tone reactivity of intrinsic muscles from decreased vestibulospinal output top down, or local inhibition at the specific joint. So with the spinal muscles, we have extrinsic and intrinsic. Extrinsic is voluntary motions destabilized when contracted. Specific conscious control, so we can control, we can choose what muscles to use. Short-lived reset of gain. So for example, if there's whiplash, then the extrinsic muscles will be very tight post-injury. And then we have intrinsic. So it's reflexive and tonically stabilizing, controls biomechanics, controlled as a group. So for example, if I tilt to one side, the opposite side intrinsic muscles will contract together. And lengthening for weeks and months when stretched. And with muscular reactivity, so high velocity stretch, a force greater than the body's ability to resist, we go beyond the speed and load limit, and then resetting the gain. And if the head goes forward to the left, for example, the right anterior, so if the head goes forward to the left, right anterior, so left posterior activation of extrinsic and intrinsic. Let me get back to that. I want to make sure that I have this right when I go through the summary, because it was so on point. I love it. Cool. So the effect of trauma on spinal intrinsic muscles. Left intrinsic gets tighter and tighter and continues to inhibit the musculature for the chronic subluxation. And then reset the gain of the right multifidus, lowers the tone reactivity and unable to inhibit the antagonist. And then we see extrinsic compensation. So failure of intrinsic stabilizers, excessive left anterior motion, recruit right posterior extrinsic, left anterior restriction, and restriction returning to neutral. So the joint can't get back to neutral or go in the traumatized position. So post-trauma, unstable in the vector of trauma, extrinsic loading creates wear and tear, alteration of the axis of rotation, less capacity to resist translation, so they get held in flexion, decreased motion or deafferentation, not getting proprioceptive feedback from the joint, or altered motion, disafferentation. So they're moving, but they're not moving how the brain is instructing them to move. So how we address it typically would be in-range adjusting on both sides, which resets the gains of the intrinsics and the extrinsics. And we're not calibrating the intrinsic imbalance. So I just absolutely love this brand new concept of adjusting to neutral, and thank you for exposing us to this. And so it's looking at spinal stabilizers first, resetting the gain of the antagonist, the tight muscle, intrinsic, and resolve inhibition of traumatized muscles, balance of intrinsic stabilizing muscles, calibration of the joints, translational adjustment back to neutral, decreased error signals, and less compensation. And then we discussed vestibulospinal output, which of course is the top-down function. And so postural training reduces stress and builds function of compensating muscles. Vestibular stimulation and rehabilitation, so balance training and gaze stability exercises, all have great potential to increase vestibulospinal output, except when there's deafferentation or disafferentation. And so rehab on top of deafferentation is just going to train the patient to upregulate other senses, and deafferentation cuts afferentation of the vestibular nuclei. So with disafferentation from pathomechanical joints, it creates error signals and the brain can't tune it out. So now it becomes harder to calibrate a system with poor inputs. And so when it comes to treating local intrinsic failure first, it's about resolving inhibition of intrinsic muscles, restoring restoring joint stability in the vector of trauma. Axis of rotation is normalized, improved control of translation, especially during impact, decreased extrinsic compensatory tension, better range of motion, improved joint mobility with better proprioception, cessation of the disapparentation errors, greater joint control, strength, stability, postural tone, and endurance. Dr. Russ, how did I get that correct with
That
the
was great. That was a really, really good summary. That's fantastic. I'm amazed.
Wonderful.
You could do it
Well,
yourself now.
we learned so much. I'm so grateful. Quick question for you. I really appreciate how you mentioned adjusting to neutral first. And we are talking specifically about head and neck traumas on this summit. If we see a patient who needs to be adjusted to neutral, but they do not have an acute injury, but maybe it's the patient who comes in and says, I have headaches and neck pains. I had whiplash a couple of years ago. So maybe they have some chronic injury there. When would you recommend doing vestibular rehabilitation, or how would you know that the deapparentation or disapparentation has been relieved so that we can start adding vestibular rehabilitation on top of their treatments?
Right. Well, obviously, there's different ways of seeing how effective their proprioceptive system is. You can use like head lasers and tasks like this. There's obviously your palpation skills. You can definitely feel the difference between a stable and an unstable spine. If people are unstable, they're going to have more wobbling. So there's obviously all of our clinical tests we can use to see what level of stability they have. And what I like to do is just make sure that all the joints are functioning really as well as they could. So I know that they're getting the best afferentation they could possibly get before we start, applying more vestibular training. One of the other things is that sometimes when we're looking at someone that's had some sort of head or neck trauma, we're often thinking, well, is it appropriate to adjust or not appropriate to adjust? With adjusting to neutral, and sometimes we think, oh, people responded badly to the adjustment. We might just be adjusting people in a way that's kind of giving more afferentation to a system that has disafferentation. So if we're trying to resolve that quickly with adjusting to neutral, what I found is that people tolerate this very, very easily. It's a very, very simple and comfortable adjustment. People often ask, is it okay to do this? And I'll say, look, if your head can move from this position to this position, then we can adjust you. So it's not really any challenge on the joints. We're moving it in a biomechanically appropriate way, and people do tolerate these adjustments very well. So for me, it just makes the most sense just to clear all the joints first. One of the things that we do, however, is we're applying our adjusting to neutral techniques to the specific vectors of failure. So I do teach seminars where we're teaching people how to figure out where that vector of failure is, where that sort of dominant vector of failure is. And so again, like with balance, like a balance board, you can do like a gaze, just testing someone's extraocular muscles and seeing if there's breakdown in eye function. These are really great ways to see where that vector of failure is of that person. So in other words, how were they traumatized in a way? If they're traumatized in a certain vector, they'll often have lesser function of proprioceptors in that vector. So they need more motion before they actually know where they're moving. So we'll often see kind of a greater amplitude of motion in the vector of failure. So what we'll do is we'll just see if there's a restriction of a joint in that vector or in that position, and then we adjust from that position back to neutral, and then see if we clear it. So it is a very powerful tool, but we also have to use it quite precisely to, at least to get the greatest benefit. So very often, I'll often just adjust someone's neck and, in one joint, and then we see how everything's going before we go further.
Wonderful. Precision for best clinical outcomes. And
Absolutely.
Dr. Russ, where can we learn more about your seminars for teaching adjusting to neutral?
Yep. So basically what I've done is I've created a three-part seminar. So the first is teaching the biomechanics, because this is a very different way of doing things. And also what we know about the mechanics of the joints now is far different than what we knew when I was studying, 25, 30 years ago. So I think a lot of people kind of need to update their understanding of biomechanics, and particularly the roles like we were just discussing between these intrinsic and extrinsic muscles, and what controls them, and what are all the factors, and what are all these things that I'm seeing clinically mean. So the first seminar is biomechanics, so people can really, really understand that. And the second one is focusing on a different sort of entry point, which is integration. So integration is basically how proprioceptive information comes together and is integrated in our brain to give us a sense of understanding of where we are. And so in that one, we're kind of applying a lot of other sort of clinical tests that are actually tests of how well our system is integrating information. And then the third module is diagnostics, which actually happening in Amsterdam, and that one is basically starting from the perspective of what we see with our patients, how people present, what muscles are tight, what muscles are weak, what is it telling us about that central function. So we're really taking everything that we see clinically and helping people understand the neurology of what that means. What is a lateral collateral issue in your knee, or a medial meniscus issue mean? What develops that? What are the patterns of muscle weaknesses and tensions that allow that to happen? And is that a reflection of what's happening in our brain? So when we understand that, then we can understand exactly how that person is failing that's creating that wear in that area, and then we can apply our treatments to help resolve that. So each adjusting module does stand on its own. You can come just to one or another, you can come to all three. So we are teaching the adjusting of cervicals, lumbars, and extremities in all of the seminars, but the entry points are different. So it just kind of depends on what people are interested in.
Well, thank you for sharing that great resource with us, understanding biomechanics, integration, and of course, diagnostics.
Yep.
And as we wrap up another great session today on the Virtual Neurology Summit, I'd like to acknowledge Dr. Russ for his excellent work in the field of functional neurology. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain-based correction and objective clinical results. I'm Dr. Krista, your host of the Virtual Neurology Summit. Be sure to check out the Postural Neurology program to get certified in brain-based postural correction. Stay tuned, and we'll see you on the next Neuro Masterclass of the Virtual Neurology Summit.